Hi everyone, it's Aditya Jasaputra here from the Alfred Hospital in Melbourne, Australia. Today I'd like to share our findings of hyperleukocytosis in patients with acute leukemia during the COVID-19 pandemic in Australia. Firstly, a bit of a background. Unfortunately, Melbourne is the most locked down city in the world, with Victoria as the state most affected by the pandemic in 2020. We've seen that lockdown was associated with a decline in cancer notifications, including blood cancers. We hypothesized that delayed presentation would have the most profound impact in highly proliferative malignancies, such as acute leukemia, in which it may manifest as a higher frequency of hyperleukocytosis, defined as white cell count above 100. The Victorian 2020 lockdown began in April here. The preceding 9 months from July 2019 to March 2020 were determined to be the pre-lockdown period. The first lockdown was characterized by a stage 3 restriction of stay-at-home orders for about 6 weeks before restrictions were eased in the middle of May, in response to the low COVID case numbers. COVID case numbers rose again at the end of June, which prompted the second lockdown of greater magnitude. Here, in contrast to lockdown 1, stage 3 restrictions were unable to control the virus, and we had to, instead of relieving, we actually escalated restrictions, stage 4 restrictions, from the beginning of August for a couple of months, and life only resumed to normal at the beginning of October 2020. This was a collaboration between 8 Victorian leukemia service providers. And on your right, we've tabled the study particulars. We collected data from consecutive newly diagnosed acute leukemia cases identified from hospital databases, and these were the variables that we collected. Furthermore, we also annotated EPI test claims as a surrogate for EPI test volumes from Medicare Australia website. COVID-19 cases were derived from Department of Health datasets. Let's look at our results. Firstly, this is a composite figure of EPI test volumes at the top in purple lined, and at the bottom, we have leukemia cases in blue with hyperleukocytosis presentation in red dots. The first observation we noticed is that there were low EPI test volumes throughout lockdown 1 and lockdown 3, with the most profound at the start in April 2020. And this was associated with a relatively low acute leukemia case numbers right here, which wasn't sustained throughout the lockdown period. Secondly, focusing on lockdown 2.0, amidst the low EPI test volumes, we see excess hyperleukocytosis presentations. There was sustained and increase throughout the 3-month period. Indeed, in lockdown 2, the median presenting white cell count was significantly higher at 10.1 versus 4.3 pre-lockdown, with a p-value of 0.029. The rate of hyperleukocytosis actually tripled at 18% with a p-value of 0.006. So how did these patients fare during the lockdown 2? Well, we delivered the same rates of active treatment in intensive induction compared to pre-lockdown during this period. However, patients who were treated with intensive induction were significantly younger in lockdown 2 compared to pre-lockdown, with a median age of 50 versus 60, with a p-value of 0.054. Furthermore, leukapheresis were also used more frequently during this period at 31% amongst patients with hyperleukocytosis. With respect to treatment response, we see a comparable composite complete remission rate and 30-day mortality here. It is to be noted that in our cohort, there's only one COVID-19 infection with a prevalence of less than 1% in the entire series. However, with respect to ICU admissions, this almost doubled during the second lockdown at 27% compared to 16% pre-lockdown with a p-value of 0.056. Indeed, the total ICU patient days per annum during this period was 660 in the second lockdown compared to 208 pre-lockdown. We conclude that during this period of the most stringent and persistent restrictions, we observe persistently low EPI test volumes associated with the excess hyperleukocytosis presentations with a p-value of 0.006, therefore confirming our study hypothesis. These were suggestive of effects of delayed diagnosis of newly diagnosed acute leukemia. With respect to treatment approaches, active treatment in intensive induction continued, but there was selection of younger patients perhaps during the second lockdown to receive intensive induction. With respect to resource utilization, these were greater as well during the pandemic, with slight increase in leukapheresis use and ICU admissions. With the short follow-up that we have, the composite complete remission and 30-day mortality appear comparable and may be explained by a number of factors. Firstly, we have moderate sample size which may be unable to detect significant differences. The treatment nuances as explained above, the low rate of COVID-19 infection in this cohort, and also the observation that in Victoria, there appears to be a reduction in community infections with viral pathogens and nosocomial infection in hospitals as well. I'll close there. I'd like to thank Professor Andrew Way as a senior lead author of this study, Lauren and Catherine, who assisted with project inception, and all my junior and senior co-authors across the state that contributed to this data set. I'll be happy to take any questions, and thanks for your attention.